So my name's Tom Jeerakathil. I'm a associate professor and a stroke neurologist at the University of Alberta, and I'm speaking today about the tele-stroke system and how to best use the resources for a tele-stroke system. When I think of efficiency, I think of it in two different ways. One kind of efficiency is using a group of using your expertise or your specialty group to maximum effect. So telehealth is a great example of how that happens. So we give clot-busting drugs in places where there is no neurologist. So really telehealth allows us to extend our reach hundreds of kilometers from where we are to places where there can't be a neurologist in order to give clot-busting drugs that still require a neurologist to actually give. So the telehealth system is very efficient in terms of using a pretty scarce specialty pool to cover a very large geographic area. So at the receiving end, we need to have a few different kinds of things. So first off, we need to have infrastructure in place. We need a video conferencing equipment of some kind on that end, which is secure and consistent with what the health system would approve. We need to have people on that end that know how to use it. We need to have emergency professionals that know about stroke protocols. They've been educated in a stroke pathway and they know how to activate the pathway. They need to know when to call into the phone referral system, which is rapid. So that process has to be there. They need to have certain skills to do something called an NIH stroke scale, which is a rapid neurological examination for stroke. So those are the things we need on that end. We need a doctor on that end because I don't have privileges in a lot of these hospitals. So I give my recommendations to a physician who then carries them out, and the physician and the nurse help me to examine the patient. And I need all this in place. I also need an electronic medical record, which we have, where I can look up this patient while I'm waiting for the CT scans to be transmitted and figure out what the problems might be that we have to deal with in terms of giving them TPA. And I need a way of accessing their brain CT images. So we have a secure system for transmitting images to what we call our central PAC system. And I can log on to this system and actually look at the patient's brain CT scan, and then immediately log on via video conference and examine them with the help of the team, and then make a decision on giving thrombolysis or not. So there are a lot of things that contributed to the Northern Telestroke network. So in terms of the geographic area covered by a single hub site, we cover an area 2/3 the size of France. So it's a very large area for a single hub site. And what we have is, the most critical thing is really a really motivated group of tele-stroke physicians. Initially, we just used stroke fellowship trained neurologists, 8 of them. And now I've trained 3 other general neurologists, very motivated to do telestroke. So we need this pool of people that are committed to actually extending the reach of stroke neurology to rural areas. So we have that group. We also need to have the other systems in place that I mentioned that are there in terms of a video conferencing structure. Well, we need something on our end. In the past, we had an ancient device that we used to haul around in a specialized case that looked like a nuclear weapon, and we'd have to pass it off between the different physicians. Now we have dedicated laptops which can securely connect with any Wi-Fi connection just using your AHS login. So we have a technological system that can connect us with the internet-based video conferencing and brain image system, all right, and also the electronic medical record. So those things are in place. We need to have a call schedule where we have these physicians available literally with 2-minute response time. So for the phone call, you have 2 minutes to respond, or you get another page. And then we need them all to be experienced. So you start to do telemedicine, and it's not the same as doing a regular consult. You have to gain a degree of experience and comfort level in actually treating patients remotely.